Let's ask the what if question. What if we were mandated that we could only look after 4 women or people having an induction of labour as opposed to the 1 to 8 that's currently set? What if we learned from the units that currently have this in place as a standard to work from across the country? This was a national standard, this was a national framework. What could care look like? So the midwife comes in at 7 o'clock and starts handover. For the next half an hour, she has handover, she makes her plans of care for the day. And then over the next half an hour, because she's only got 4 patients, she starts walking around one at a time. And what they do is they introduce themselves, they say hello, what they're going to do for the day. They explain everything. Now these 2 are due for re-examination and also for a new induction of labour agent if their waters cannot be broken at 10 and 12. So we've started to space these out much more evenly. This person's waiting for her waters to be broken, and that can happen in the next half an hour because there will be a bed on delivery suite. At some point we will get someone else in having her induction. This person's got a catheter balloon in for the next 6 hours. She's already had it in place for 6 hours, and once that has finished, we can then break her waters on the ward. So we start our shift by taking this person over to delivery suite and handing over care. That leaves us with 3 currently, but we have got 2 more women needing inductions in the day. So we will call them up. We're going to bring one in this morning, later on in the morning, and we'll bring the other one later on in the afternoon so that we've got that space, and also it means that we've got time to be able to take one person up as well. We go in and we start our ward rounds, and this person is saying that they're uncomfortable and they're in pain. So what we're going to do is we're going to go and check out some pain relief, we're going to examine, we're going to sit with them for the next half an hour, monitoring contractions, monitoring their baby, providing that reassurance and support on a one-to-one basis. This person is going to feel heard, seen, listened to. They're going to feel supported in this case because the midwife is not going to be rushing in and out of that room. She's going to spend that time with them, providing that reassurance and that pain relief, examining, assessing, finding out what's going on. Once the pain relief is effective, we provide that call bell and we say we'll come back in an hour just to check on how they are unless they call us sooner. Their cervix is 2 centimetres dilated, the ProPress is removed, and they're now waiting for a bed on delivery suite. We go into this room and this person is due a reassessment and is due a dose of Prostin if the cervix is not open enough. So we spend the next hour monitoring her baby, checking her over, find out the cervix is still long closed and not open, so we're going to insert Prostin gel at this stage. We are then going to sit with them for the next half an hour, again talking about birth plans and birth preferences, things that they want from their birth. We're going to talk about birth affirmations and getting up and mobile and moving around. We're going to provide a birthing ball and a peanut ball to help optimise this baby's position. And then once the monitors are off, after an hour of that Prostin being in, this person can then go for a wander and a walk and try and think about the biomechanics to get their baby in an optimum position for labour and birth. And we've checked back on this individual. They are nice and comfortable and settled, and delivery suite are happy to take them in the next half an hour. So in the meantime, we have our 4th induction come in. Okay, so this is our first one that we're going to start the process on during the day. We go in and we say, hello, how are you? We introduce ourselves, we sit down with them and we ask them what information have they had so far today? What have they been provided with in the antenatal period? Do they have any questions? Do they understand the process, the time length? Do they have all of the risks and benefits or just some of them? How does it look currently within this unit? And we sit down getting to know them, getting to know their wants, their wishes, they might want from their birth preferences, and who's going to be supporting them. We get to know them. We provide that personal, individualised care. We pop on the monitors, and what we do is we go and check this other person and take her around to delivery suite. So she has now gone. So currently we have still got 3 patients in. At the point we will have a new induction come round this afternoon. We spend the next hour popping on the monitors, observing and assessing the cervix to see if it's open enough. We insert the induction of labour agent, whichever method that will be. We advise them that once the monitors are off, after the monitoring is completed, they should be able to go for a walk and a wander, and again, help baby get into an optimum position for labour and birth. Within this, we haven't rushed anybody at all. We walk into this room and this person now can have their catheter out. So they've had a balloon catheter induction. And what we have got here is that we can break waters on the ward as long as delivery suite are happy for us to. We can start that process off here if they are happy. So we spend the next half an hour talking through the process, the procedure, the pain relief that's available. We sit with them, we provide them that time, we answer any questions, we ask if they have anything they want us to do, we monitor their baby, we do a full thorough assessment with observations. And then we gain consent. Are they happy for us to break their waters? So we go ahead and do that because we've gained consent now. Once those waters are broken, they're nice and clear. The cervix is 2 to 3 centimetres dilated after the balloon catheter has been removed. They can now go off for a wander and a walk for the next 4 to 6 hours until they're ready to start the hormone drip at that stage. Of course, if anything happens where labour starts spontaneously at this point, if there's pain, any discomfort, any concerns with movements, anything else that goes on, of course they can come back and we will start that assessment again. We go back and we check on this individual to see how they're getting on, and they're nice and comfortable. The prostaglandin hasn't made them uncomfortable in any way, shape or form in this case at this moment in time. They've been out for a walk and a wander, they've come back, they've had their lunch, and now they're going to go off and have another walk up and down some stairs and around the unit itself. We have now got a little bit of a break and a breather. So we are going to go for our break. We're going to go and take 45 whole minutes at this stage, and we're going to refresh and replenish before our next induction comes in and before we do our next round of observations and monitorings on babies. So we've come back from our break. This person is out wandering the unit. This person has come back and they are now saying that they are quite uncomfortable. You sit with them for the next 45 minutes, feeling their tummy, listening into baby, and just assessing what's going on. You think that this person is establishing now, so you have another phone call conversation with Delivery Suite, and you decide that they definitely need to go round. You've offered an examination, and this has been accepted, and the vaginal examination shows that the progression of labour is now 6 centimetres established labour. So this person is going to go over to Delivery Suite and will have handed over all of those birth preferences again, that individualised care plan that has been made, and that person feels seen and heard and listened to. So you go back in and you check on this person, and this person remains very comfortable. They're due reassessment in 2 hours, where then the examination will show whether there's any other induction of labour agents needed or whether they can go up to Delivery Suite to have their waters broken. You pop back into this room because they've just returned and they said that they're a little bit uncomfortable actually from the ProPES having gone in. Can they have some pain relief? So you go and get the pain relief, you sit in there for the next 20 minutes, again feeling their tummy, finding out how often they are. They're about every 6 to 7 minutes. You have a listen in, you do their observations, you document all of that, you see how they are, provide them the paracetamol, dihydrocodeine or whatever it is that they can have at that stage. They're like, yeah, that's okay, I'm going to go for a nice warm bath at this stage. Because your unit has it, you also offer them a TENS machine as well when they get out of the bath. Then your next person comes in for an induction of labour and you go in and do exactly the same as what you did with this individual. You spend the next hour getting to know them, really getting to know their wants, their wishes, running through induction of labour start to finish, making sure that they have fully informed consent about the whole process start to finish. And you go back to this individual, you reassess them for the day, you check on this individual, you make sure that they remain comfortable, and they have. The paracetamol dihydrocodeine has worked quite nicely, the bath has made them feel more relaxed and has settled, and those contractions have fizzled out a little bit. So again, providing some biomechanics, how to get baby into a good position, all of the information that this person needs to help them. The midwife comes out feeling like they have done a cracking job for the day, that they have supported women on an individual basis, that they have come in to do what they are meant to do, which is to provide care for people. What if we learnt from the best units that mandate safe staffing in induction of labours, in antenatal care settings and postnatal ward settings? Our retention of midwives would go up, our satisfaction and our experiences from women would improve, our safety, paramount for everything, would improve overall. People would come out with less birth trauma, people would come out feeling less like they were not listened to or heard. They would feel far more cared for. They wouldn't feel ignored in an antenatal ward in pain and uncomfortable because the midwife has got 7 other patients that they are looking after, all ongoing induction of labours. They would feel like they would have pain relief when they asked and requested it. They would feel like they could have a good, positive experience where they were supported, fully informed, listened to, where they were provided time, and they were provided time to be able to ask those questions and not rush through, not a conveyor belt. A big what if is what if we mandated safe staffing ratios overall and really invested in that. And what's needed is funding. So funding from central government, but with outcome and process measures put in place so that trusts have to spend that money to mean that they are meeting safe staffing levels. If we just give trusts lots of money, it's not necessarily going to hit the frontline services. What you need is a safe staffing template from either the unions or the national bodies or from this maternity review saying that you need 1 midwife per X amount of postnatal women, 1 midwife per X amount of antenatal women, 1 midwife per X amount of induction of labours. You need this to staff your triage properly. You need to start monitoring that so that we are safely triaging people. day assessment units and community centres exactly the same way. And what we want is we are going to put this money in, but you have to show us from a report your workforce model and how that now looks from that funding. So for example, you now have 2 extra midwives on the ward so that you can now meet the 1 to 6 families postnatally. You can meet the 1 to 4 induction of labours at any one time because you've increased your staffing workforce. You have X amount more community midwives so that your caseload numbers are slightly smaller. And that is what you have done with that funding, and that is a sustainable model. This is what we have now got. This is what we are going to continue moving forward. We are going to follow these standards. We're going to follow these frameworks. What if isn't an easy task because that requires a lot of central funding. When we are thinking about staffing models of care 24/7 so that everyone has the adequate care hours needed to meet the care hours needed from the women, it is a lot of money, and I guess those questions have to be asked at governmental level. What is maternity care worth? What are we doing in terms of investing in it? And what could the art of the possible and the what if leadership question could be?